today. Dr. Brian is the Stress, Trauma, and Resilience Professor of Psychiatry at The Ohio State University Wexner Medical Center. He's an expert on suicide prevention and interventions for suicide prevention and related conditions like post-traumatic stress and issues common in military personnel. He's written over 200 peer-reviewed articles, and I think it's 3 books. Is that correct, Dr. Brian?
Yeah, something like that.
Yeah. So, I mean, he's about as good of a source as you can get on the subject of suicide prevention. So I think we're really, really lucky to have him today and hear his insights into screening for suicidal ideation and suicide risk, and assessing for that risk in clinical settings. So with that, I'll turn it over to Dr. Brian.
Okay, well, thanks so much, David, for the introduction, and thanks for inviting me to spend some time with you all today to talk a little bit about some of the research that we've been conducting over the past few years, with a particular focus on some of the newer ideas that I think are highly relevant for suicide risk assessment, screening, as well as intervention. I'll decide to focus the conversation today. I'll spend maybe about 20-25 minutes talking about some of that research, and then would love to open it up for questions and discussion that people might have. In terms of financial relationships, it's on the screen right now. I have received grants and am currently grant funded from multiple federal agencies, but also receive a lot of consultant fees and payments to do workshops and to consult to help develop products related to suicide prevention, but none of those products will be discussed today. Okay, so jumping right in, I want to begin by talking about sort of where we've come from. And historically, and I would even say today, the prevailing perspective of suicide risk is to conceptualize it in terms of some kind of like a spectrum or continuum, where on the low end of the spectrum, we have, people who are not experiencing thoughts about death or suicide, maybe more mild forms of suicidal ideation, sometimes referred to as passive ideation, involves thoughts that wish that one's life is not worth living or wishing that one was dead. And then we can sort of climb up this sort of theoretical continuum of increasingly severe levels of suicide risk, where we get into active forms of suicidal ideation, transitioning into active suicidal planning, and then starting to move into the behavioral domain, with suicide attempts being at the upper end of that risk spectrum. And I notice here suicide attempt includes not only non-fatal suicidal behaviors, but also fatal suicide attempts. The act of attempting suicide is one piece of it, and then of course there can be fatal outcomes or non-fatal outcomes. So here suicide attempt includes sort of like a nested subgroup, death by suicide. And so most of our suicide risk screening and assessment approaches are really largely based upon this continuum and our assumptions about how a person progresses from a low risk state to suicidal behavior is also heavily influenced by this theoretical continuum of risk. If you look at, for instance, different theories of suicide, I would argue that all of those contemporary models of suicide can largely be kind of captured by this particular pathway, whereby a person begins with elevated emotional distress, and then things happen or risk factors occur such that the person transitions from a state of high emotional distress to a state characterized by active suicidal thinking. And then again, they can progress, more things happen, mechanisms occur, risk factors are introduced, and then a person transitions from the ideation stage to the actual behavioral attempt stage. Another key assumption of a lot of our approaches to suicide risk assessment and treatment is that in the time immediately preceding the occurrence of a suicide attempt, there are these so-called warning signs, these things that theoretically become manifest or obvious to external observers, and that is the signal that a person is about to engage in suicidal behavior or is in a high-risk, vulnerable state. Now, the problem, of course, is that despite the prevalence and the persistence of these sort of continuum-based models, they actually don't really work very well for explaining suicidal behavior. And we'll focus today in particular on suicide risk screening within general medical settings with an eye towards primary care in particular. And I'm going to talk about 3 key reasons why these traditional assumptions about suicide risk screening probably don't work as well as we would like. And then we'll talk a little bit about what that means for actual clinical practice, as well as some new ways forward. So the first limitation that I'm going to talk about is that suicide risk is inherently dynamic. So it's an ever-changing construct. And this is something that I think we've understood intuitively for decades, but it's only been within the past, I would say, 10 years maybe, that we have really started to quantify this and understand it with much more rigorous scientific designs. And so on the screen right now are the results of one particular research study conducted by Evan Kleiman up at Rutgers University, published several years ago. And what they did in this study is use an assessment technique called ecological momentary assessment, or EMA. And EMA is a rapidly expanding and growing research design tool that has really become enabled by the advance in technology, particularly smartphones. And so with EMA research, what we can do is send push notifications or text messages to people multiple times per day to ask them to fill out surveys and to assess various outcomes, whatever it is that we're interested in. And so in this study, Kleiman did that, focused on suicidal ideation, where multiple times per day he would send notifications to patients and ask them to rate, among other things, the intensity of their suicidal ideation at that moment in time. And you can see here that the results indicate that suicidal ideation is a very noisy, very chaotic construct that is constantly changing, sometimes within the span of a few hours. One of the, I think, important findings of this research study, for example, was that 90% of suicidal patients experience a 1 standard deviation or larger shift in their suicidal ideation within the time frame of a few hours. And you can see that at several points in some of the highlighted cases where there are these sudden spikes in suicidal ideation that very quickly resolve. And so suicidal episodes oftentimes emerge very rapidly and then can sometimes resolve very rapidly as well. And this is, kind of leads us into the second key limitation that I think we're starting to recognize more and more. Again, something that I think is intuitive. People have been talking about it for decades, but it's only been of late that we've really been able to measure this in a reliable manner. And the second limitation then being that changes in suicide risk can be sudden and discontinuous, where it's not a slow, gradual, smooth change process, but backing up again, as you can see, it's very jagged, very sharp, very sudden. That is the discontinuity that often occurs. This is something that's a kind of a central piece of my research program right now, where we're using more sophisticated mathematical models to look at these discontinuous change processes to understand how a person can move from a low-risk state to a high-risk state very rapidly, and might there be indicators of when a person is about to make that shift. Well, these sudden changes in suicide risk is, I think, one of the reasons why we see consistently over and over and over again, we've known this for a long time, over 50% of individuals who die by suicide do not mention suicidal thoughts in the time leading up to their deaths. We've seen this if you look at a screening study, something, again, we've known for decades that about 50% of patients will deny suicidal ideation or screen negative for suicide risk right before they attempt suicide or they die by suicide. And so screening has this very low sensitivity. It always has, but we often don't recognize that and realize that. And I think it's going to be that poor sensitivity is magnified in general medical settings where the overall risk level of the population is much, much lower than what we would see, for example, in an inpatient psychiatric setting or even an outpatient specialty mental health setting. This is actually brand new data. It's actually under review right now, and we've received a revise and resubmit. So I'm sort of cautiously optimistic that we might get this accepted for publication soon. What we've done here, these are 52 patients who were screened in primary care out of a sample. The entire study included over 2,700 patients across 6 different primary care clinics, and we followed them for a year. And what we find is that at the top, we see that less than half of the patients who eventually attempted suicide actually screened positive. And so we missed more than half of the patients we were trying to detect. And what we did is we looked at, well, is the problem that these are sort of first onset suicidal episodes, or another possible hypothesis that many of us have been considering is that, you have some people who have previously been suicidal, but they've recovered. And so we can think of it as more of a chronic health condition where there are acute flare-ups and then periods of remission. There's, again, if you think of some of those slides that I showed you before with Evan Kleinman's work, we kind of see that variability in the construct. And so maybe part of the problem is we're missing people just because they're in a period of relative calm or in temporary remission, and then there's a resurgence of the condition that comes later. And what we find is that that's true for some patients, but it's not for others. And in the end, we see that over half of those who attempted suicide said that they experienced a sudden onset of suicide risk, wherein their thoughts about suicidal ideation emerged on the same day that they attempted suicide, such that the thoughts and the behavior sort of came into being at least subjectively about the same time. We even see a small subset of patients, and we're consistently seeing this now in several studies, around 10 to 16% who deny any form of suicidal ideation before their suicidal behavior. And so it truly is sort of this out of the blue phenomenon. And I think the reason why this is very key is because there are many, many people, especially within the suicide prevention community, I used to be one of them, who have really pressed hard for universal suicide risk screening for every single patient at every single appointment in primary care, under the assumption that more frequent screening will increase our ability to detect or identify these patients. But what these data suggest is that actually probably that won't be enough, because we would have to effectively screen people every single day of their lives, perhaps even multiple times per day, in order to capture the emergence of a suicidal crisis before it happens. And people just don't visit any medical setting with that amount of frequency. So that kind of shift from an indicated to a universal suicide risk screening, at least in primary care and other general health settings, probably actually is not going to meaningfully improve suicide risk assessment and prevention efforts. It will, however, of course, increase lots of false positives, which could have other ramifications like misallocation of limited resources. So it's kind of a tricky topic, and something that's increasingly being, I think, discussed within the suicide prevention community. The third key limitation that I think is implicated by a lot of these findings is that suicidal thinking is probably a lot more heterogeneous than we have traditionally assumed, and also than what we typically assess or measure within clinical practice. It's actually, before I show that, maybe when we look at kind of classic definitions of suicidal ideation. For instance, the CDC, NIMH has formal definitions for suicidal ideation, and those definitions typically involve language such as, thoughts about engaging in self-inflicted death, thinking about or planning one's suicide or suicidal behaviors. And so in essence, it's kind of this very narrowly defined construct that requires the explicit consideration of death first, but also self-enacted or self-directed violence as the method or the vehicle by which death is achieved. But what we're seeing now, like I said, with some of those previous studies, is that there's a significant percentage of patients who are consistently saying, I'm not having those thoughts. Even on the day that I'm trying to kill myself, I'm not having thoughts about killing myself, which often seems almost sort of contradictory, but we're starting to do a lot more research now looking at a wider spectrum of suicide-related thought processes. And there are two instruments that have really been the focus of my lab's research over the past several years. On the left-hand side, this is a new assessment tool that's been developed. It's referred to as the Suicide Cognition Scale, and we've revised it since the initial version came out. You can see here that the SCS includes these statements that are not, they don't include that explicit content about death, suicide, or wanting to end one's life. A couple of those at the bottom start to get into that realm of death and suicide. But these are all thought processes that really convey a very heightened state of emotional distress, but also a distorted sense that one is able to manage or effectively endure those emotional states. And what we've seen now in multiple studies is that responses to these items, these thought processes in essence, are very highly indicative of suicidal behaviors. They actually outperform classic methods for assessing and screening for suicidal ideation. Our most recent study, one that's in press right now, I was told it's going to be published in the next few months in Annals of Family Medicine. We look at the suicide cognition scale in a primary care setting and compared it to the PHQ-9. And found that basically any item off of the suicide cognition scale did better than the PHQ-9 at identifying the patients who attempted suicide in the next 30 days. We broadened the window as well, and it's sort of like no matter how far out you go, 90 days post-baseline, 6 months, 12 months post-baseline, the suicide cognition scale is always outperforming these classic tools that we've used to assess for thoughts of death and self-harm. We have newer analyses in the works right now showing that the reason why, or at least one possible reason for this, is that suicidal ideation is primarily a good correlate or predictor of suicidal ideation. It's not actually a particularly reliable indicator of suicidal behaviors. The suicide cognition scale items, however, seem to distinguish ideation versus behaviors. So there's something about these thought processes, these statements, that reflect a transition from thinking about suicide to acting upon suicidal urges, whereas suicidal ideation by itself actually doesn't really seem to be a particularly useful correlate or indicator of suicidal behaviors. So if you kind of think back to that hierarchy or continuum of risk that I started with, in essence, what we're starting to learn is that suicidal ideation maybe is not on a continuum with suicidal behavior. Maybe these are actually two distinct constructs, such that some people who attempt suicide also have suicidal thoughts, but there's another group of people who attempt suicide who do not have suicidal ideation as we have classically defined it and measured it. Now, on the right-hand side of this slide, this is another measure that we've used in our research. It comes from the Self-Injurious Thoughts and Behaviors Interview, or the SITB. A lot of fascinating research on this, where, for instance, Alex Milner has done some research where he will ask patients a a gate question like, are you having thoughts about suicide? And then regardless of their answer, he'll introduce this sort of menu of options, these 8 statements, and say, well, have you had any of these thoughts? And he's found that a significant number of patients who say, no, I've never had thoughts about killing myself, will nonetheless endorse one or more of these items. The most interesting, of course, is that some of them will say, no, I've never thought about suicide. I have, however, thought that maybe I should kill myself. And what we're starting to realize is that language matters a lot. And so the terminology and the language that we often use as healthcare providers doesn't always match the subjective experience of our patients. And so what ends up happening is that we'll ask them about suicidal ideation based on our conceptualizations, but it's not how they're actually experiencing suicidal ideation. So there's this mismatch. Now, we're finding as well in our research that people will actually attempt suicide by skipping these sort of suicidal ideation or suicidal planning stages where they wish they weren't around anymore, which you might say, well, that's not really active suicidal ideation, but they can sort of leapfrog from that thought process to suicidal behaviors. We have looked at in primary care settings, these are the 3 items, the ones I've highlighted on the screen, that are the actual best performing items. So you see here that this sense that it's unbearable when I get this upset. I can't imagine anyone being able to withstand this kind of pain. It's this urgency, this sort of mental, I have to do something right now, that seems to be very, very indicative of suicidal behaviors. And then the third one that kind of gets into the realm of death and suicide, which is I don't deserve to live another moment. Some of, I think, the implications for this is that in addition to screening for suicidal ideation, you know, amongst patients who, for instance, screen positive for depression, there might be a lot of value in also adding 1 or 2 of these suicide cognition scale items. We were able to show, for instance, that adding even just 1 of these items significantly improved the precision of identifying the patients who are most likely to attempt suicide in the next 30 days. So then I think another big gap, though, in suicide prevention is that we've largely focused on screening processes. I think it's because it's easy to screen. You just add a question, you add a scale, whether it's a paper and pen version, whether it's on a tablet, or whatever system that you have in place in your clinic, and then you say, we've done something useful because now we're asking the question, and that's an important part of suicide prevention. But we often forget that really the thing that matters the most is what we do, the intervention that's received by a high-risk patient. And this has also been shown empirically that screening by itself does not actually prevent suicidal behaviors. It's suicide-focused interventions that, in combination with screening, can actually lead to reductions in suicide attempts. And so one of the interventions that we have been focusing on and refining over several years is called crisis response planning. Some of you may be familiar with the safety plan. The safety plan was based on crisis response planning, and so it's kind of a more administrative approach to this psychosocial intervention, where in essence we sit down and we collaboratively develop with patients how to recognize when you are increasing in risk, and then what to do about it. What are the self-regulation strategies you can employ as a coping strategy to replace suicidal behavior? We also identify sources of social support, crisis and professional hotlines, and then another key part of our research is spending some time talking with patients about their reasons for living, or what gives them a sense of purpose and meaning in life, because we have new data suggesting that conversation, just why do you want to live, or what gets in the way of a suicide attempt, helping someone to remember those positive parts of their life leads to more rapid resolution of suicidal episodes and seems to confer a longer-term defense against a recurrence of suicidal behavior. I'll add here the approach to crisis response planning that we've tested and shown to be effective in a randomized controlled trial and was actually developed in a primary care setting. I worked for many years in an integrated primary care behavioral health clinic, only had 20 to 30-minute appointments, and so we learned how to very rapidly deliver suicide-focused interventions, and now we have the data that shows that it is highly efficacious, reduces suicide attempts by about 76% as compared to treatment. Another key intervention that we've been doing a lot of research on involves lethal means counseling, especially lethal means counseling focused on firearm access. We just published a study within the past year showing that basically a 10 to 15 minute lethal means counseling session based on motivational interviewing principles led to a significant increase in participants actually storing their firearms more safely, whether that was through gun locks, gun safes, or some other process. We have newer data that's coming out showing that sort of immediate impact on the person's willingness to use safe storage devices actually mediates or explains that behavior change. And so we have this sort of 4-stage counseling approach that really I think is very patient-centered, and now we have randomized controlled trial evidence suggesting that it actually leads to the change that we want, which is an increase in safe storage practices. I would add here one thing about lethal means counseling that many of us are recognizing is that the counseling really needs to occur before the person is suicidal. But very key for firearm owners, because if someone is in crisis and they have access to a loaded weapon, there's a 90% chance that they're going to die if they use that weapon. And so waiting for someone to be suicidal to have a conversation about lethal means access is oftentimes too late. And so we've been approaching this as more of like a public health injury prevention model where we could ideally change social norms around safe storage in the same way that decades ago we changed social norms around things like drunk driving, wearing seat belts, things like that as a safety precaution. And then one final point, future directions. We've also been working on technology adaptations of a lot of these interventions. This is one project where we've taken suicide-focused cognitive behavioral therapy, empirically supported. It reduces suicide attempts by 50% or more. We've now created a digital therapeutic version of that. We're about to start an IMH-funded trial to assess its efficacy. We've already demonstrated patient safety and tolerability, and I think general medical settings could potentially be a very impactful place to implement something like this, because the majority of people who die by suicide do not seek out specialty mental health care. They're much more likely to go to primary care, emergency departments, or general medical settings, and so this could potentially be a digital prescription, something that a healthcare provider could prescribe to their patients to deliver this highly effective, empirically supported intervention, especially for those who maybe don't have access to specialty mental health services, or just aren't interested. They just don't want to go. More to come on that. So we're still in the early phases of development and testing there. So I'll wrap up there. I've got my email address on the screen if anyone has any follow-up questions or would like any additional information afterwards. But I'm happy to entertain questions or discussion. I would love to hear any thoughts or comments that you might have about anything that we talked about today.
Fantastic. Really, really useful stuff. I really love that you blended a lot of your findings with a lot of clinical takeaways, and certainly a lot to think about for our group. So yeah, people, feel free to, any of our participants, feel free to jump in with questions, or you can enter in the chat if you'd like, and I'll read them off.
Hi, Hi, I have a question. I'm Dr. Islam. I'm the program director in UTMB Family Medicine. You mentioned about the randomized clinical trial, and you said 75% efficaciousness of the intervention that you all had.
Yes.
Could you, let me see if I can put up my, there you go. You can see my face, sorry. How long was that study? I mean, 1 year, 2 year, 3 year?
So we did a 6-month follow-up.
6 months.
Yes.
So the next question would be, I know there are some diseases that we really have to follow up for a longer term to get the final result. So do you think 6 months was enough to get the result that we really want to know?
Sure. So yes and no. The yes answer is, when we first started this study, my hypothesis was that this 30-minute intervention is only going to last for a month. There's no way it'll be any good after that. We actually found the effect increased all the way out to 6 months. So that was an unexpected finding. So the no part of that answer is that I think this is a matter of patient subgroups. There are some patients for whom I think this brief targeted intervention is exactly what they need. There are other patients, especially those who have more chronic or persistent suicide risk, where they've attempted multiple times, they have chronic psychiatric disorders, where I see this as more of the short-term management, and they would benefit more from ongoing suicide-focused psychotherapy. And so that's a big question that I have right now of who responds to what, because I do think one of the worries that I do have is that those results and some other studies with similar results have led the field as a whole to think that's all we have to do. And I really see that intervention as being akin to some of those acute care stabilization types of interventions that just serve as the gateway to longer term treatment.
Thank you. A great lecture, We need more of these because really we get puzzled at what to do with this. People who have these thoughts of hurting themselves, and it's so unpredictable. I mean, very unpredictable. So I think so you're right in finding out which type of suicidal person that I'm dealing with. Is it a chronic suicidal thought process or just a, passing by suicidal thoughts? So yeah. So maybe the other thing that might be a good, interesting study point is, can we do these booster doses on the intervention that you talked about? Bring them in 3-6 months and rehash the things that you said the first time and might be in the long run could help.
Yeah.
Good talk.
Yeah, we've published some follow-up data showing that, the patients who use the intervention more frequently have larger benefit, and it's sort of like, the medicine only works if you take the medicine, right? And in clinical practice, when we work with a lot of our patients, that's the model that we tend to take, is that here, let's get you to a point of remission, and then how would you know when you need to come back in, so that perhaps it is something that you just periodically revisit over the course of your life as you experience relapse or recurrence of the condition. So yeah, I think that'll be incredibly valuable research. I'm hoping we'll be able to do that soon.
Yeah, I think so. We should treat this thought, the suicidal thought, as a disease. And if we can bring in diabetic patient every 3 months, why aren't we bringing them every 3 months?
Right. Yes.
Yeah. Thank you.
We've got a question in the chat that asks about the role of culture in any of your work, and I assume with suicidal ideation. So I wonder if you could comment on how maybe you've looked at whether some differences in culture identification sort of impact your results, or how that relates to expressions of suicidal ideation?
Sure. Yeah, we have done some secondary analyses of our clinical trials to look at, different demographic moderators. We've looked at gender, race, ethnicity, even, subgroups based on like diagnosis, things like that. And what we find is that the advantage persists regardless of how we sort of slice the pie. One other thing though that we've found really helpful from a cultural perspective, I did not talk about it here, but when we do a crisis response plan, for instance, we actually precede it by with a process that we call the narrative assessment. And so it's a suicide risk assessment, but most of us think of a suicide risk assessment as an interview. And so I ask the patient a bunch of questions like, how often do you think about suicide? What are you thinking about? Do you have a plan? What is your plan? Do you have access to the method? It's like this interrogation, so to speak, because then we have to document all that information. What we have learned to adopt is this storytelling approach where we ask the patient, can you tell me the story about the day you tried to kill yourself? Or can you tell me the story about, last week when you really were having these intense thoughts? And what we have found qualitatively, we've not studied this, rigorously yet, but we have received very positive feedback from ethnic minority groups, especially Hispanic and Native American, First Nation groups, as being very culturally sensitive. There's sort of more of a storytelling-based approach within those cultural groups, and they sort of respond better and appreciate it as compared to kind of the more westernized, I'm the expert and I ask you a bunch of questions. So we've definitely so there's no like research findings yet related to that, but we definitely have been observing this, and it's something that we've been thinking about. The other cultural aspect that we've really looked at is, most of my work is with military personnel and veterans, and so we've even worked with that group through sort of a multicultural lens, and really thinking about what's the language that we use with that group, and how can we generalize that to other lived experience and population subgroups to match the terminology, match the concepts to their background and their life experience. So I think that's been very valuable in our work, and it's something that I would certainly encourage all of you to employ. How do they talk about it? How do they think about it? And then how can we now present the intervention in a way that fits with their subjective experience in life?
Great. With another question regarding the testing of these interventions for suicide prevention in low literacy patients, or I assume patients who may have intellectual difficulties, or patients who are lower on the reading literacy, given the response, given the format of the crisis response planning. So I don't know if you've tested that or you have any insight into that.
Yeah, we've not formally tested it, but if you recall the slide that I had with the examples or index cards, and it's like just these bullet points, that was largely influenced by this particular consideration. Some of the earlier kind of manifestations of crisis response plan were much more verbal. It was almost like these complex sentences, and what we learned is like, no, it just needs to be simple and to the point. We've had cases as well, like with severe TBI, somewhere. My suspicion was it was, like a early onset dementia or early stage prodromal, cognitive disorder, where we've even made adaptations where we like draw pictures of the concepts instead of having the more kind of verbal, text-based. And so, more to come. I get questions about children as well. How do we do this with children with lower, developmental, just cognitive levels? And that's sort of our advice right now. But again, we've not formally tested those techniques or procedures.
Great. And there's a question about the suicide cognition scale. So you mentioned that there were 3 questions that were sort of the best indicators of suicidal behavior. So is it advisable to add those to the PHQ-9? And the question asker is asking, should we add these to our PHQ-9? So I'm assuming, is that something that's good for clinical settings?
Yeah, I mean, the data that we've collected so far suggests that it could be quite valuable. And so it's a 5-point. I can send a copy to David afterwards. And so, but it's like a 5-point Likert rating scale. People assess, I strongly disagree, neutral, agree, strongly agree. But whether you add it to, paper pencil form, or if you use tablet, electronic devices, I think it could be a useful addition. And what we showed in our paper was that basically a score of 2 or higher was sort of the best threshold. And it was a combination then of, scoring high on the SES item and that PHQI item 9, where it was like that was the subgroup who had a much higher density of suicide attempts within the next 3 months. So yeah, I'll pass that along, and if you guys decide to try it out, I would be willing to answer any questions, help out in any way that you can. I would be interested in sort of how does it work for you all from more of like an implementation effectiveness type of perspective.
That's great. Yeah, anything you're willing to share with us, we're happy to share on our resources collection, as well as whoever wants to put it into clinical use. We'd love to hear about it. So yeah, we could do that.
Yeah, I'll add as well, when we have had various clinicians use it in their practice, and what they have found is that it often, what the clinicians say is that it sort of facilitates more useful conversations with the patient, because there's a lot of shame and stigma around suicidal ideation. If you look at Richards and Greg Simon published a paper a couple years ago looking at, well, who's this subgroup that say, no, I'm not suicidal, but then attempt suicide like 30 days later. And what they found was that the most common explanations that patients provided for basically screening negative, one was, I was afraid of what my doctor would say and how they would react to me. Then the other leading response was, well, I mean, at the time I wasn't actually having those thoughts. And then the third leading response was, well, the item doesn't really, the words that it used doesn't really capture what I was experiencing. And so there is this element of I'm uncomfortable talking about it, doesn't match my experience, and that's where the clinicians have said it was really useful, because the patients will say things like, this is like literally what I say to myself, like this is what's going through my mind.
Great. I have a couple questions I'd love to get in, but if others want to jump in, you can feel free to throw it in the chat or just interrupt me. So first, given that the current pandemic seems to be really forefront on a lot of people's minds, and I'm sure you're getting this question a lot, some of the data that we have reviewed lately seems to suggest that there's some controversy over elevation in rates of suicide during the pandemic. And I think from my perspective, at least from my reading, is that it seems that there's a good amount of the evidence suggests that over the course of the pandemic, we've seen sort of a steady increase in suicide rate. And I don't know if that's consistent with what you've seen. I'd love to hear your perspective on suicide rates during this sort of trying time.
Yeah, so there was just, it is a controversial topic. The data that have come out thus far in the United States, as well as several other nations, suggests that at a population level overall, there's been a reduction in suicide rates. There's some evidence of an increase in suicidal ideation. Some are saying depression rates are increasing, anxiety rates. My perspective is, well, I don't know if it's an increase in depression so much as it's an increase in stress, but stress isn't necessarily a mental illness. But it seems as though death by suicide rates have been dropping during the past year. Now, a couple caveats. That's at a population level, and at a national level, for instance, that seems to be largely explained by reductions in suicides amongst white Americans. There's evidence of an increase amongst Black Americans and possibly Hispanic Americans as well. And so the overall reduction reflects that there's been a reduction in the majority racial ethnic group, whereas vulnerable and traditionally disadvantaged subgroups are actually showing the reverse pattern. And so it's, I think, a complexity, a nuance that we need to keep in mind. A second element of this that I think is really important to keep in mind that is often overlooked is we attribute these changes to the pandemic. And, you know, well, all this happened in 2020 and there was COVID. And I was like, well, you know, 2020, a lot was going on that year, especially in the United States. And we often fail to recognize the potential role of social unrest and political tensions that occurred in the nation. And so, you know, I certainly can't speak for everybody here, but I mean, when I think of increasing stress levels during 2020, I've certainly noticed most people were saying is around November, from November to January, where people were really on edge. And during that time, it wasn't so much COVID that people were attributing that distress to, but social political tensions within the nation. And so I think that's another really important social factor that is, I think, I would argue has been completely overlooked. And I think it also probably is related to these subgroup differences that we're seeing across races.
Glad to get your insight on that. I'm also curious, I bet members of the audience would be wondering if they wanted to get trained on evidence-based assessment, screening methods, and brief intervention methods like you discussed, where would they go for that?
Oh yeah, you can reach out to me. We do trainings all the time on these topics, and so yeah, if people are interested, we can put something together. Usually what we're asked about is like crisis response planning or lethal means counseling. You know, we have different, you know, half day, full day, those sorts of things, depending on, you know, the population, the target audience, and what your needs are.
Awesome. So I'm just going to put your information on our website for people to go to you and your lab and your program if they're interested in that.
Yeah. You know, one other point that I'll make that I think, because I've just mentioned lethal means counseling there again, that I think is relevant to your previous question about COVID and 2020 is that, you know, another major focus of my research is on firearm suicide. And during 2020, it was the highest gun sale year in U.S. history. And what's interesting, we've got new data on this. The people buying the firearms are not who most people expect. You know, when I quiz audiences, who do you think was buying all the guns in 2020? They're like, oh, it's probably like middle-aged white men who live in rural areas. And I was like, wrong. Actually, it was disproportionately racial ethnic minorities, sexual minorities who live in urban areas who are now first-time gun owners. They previously were not gun owners. And I think that, again, goes back to the point I was making before. I don't know if it was COVID-related. I think there's a strong case to be made that it was related to social political tensions within the nation. But I think this is relevant, and the reason why I bring it up here is because, you know, the presence of a firearm in the home increases the risk that someone in that home is going to kill themselves by fivefold. And likewise, removal of the firearm or safe storage, so locking up the firearm, reduces the risk of suicide. It offsets or protects against that risk factor. And so the downside, of course, is once people have a firearm, they tend to keep the firearm. And so it becomes this sort of chronic, persisting environmental risk factor that I think increases suicide because it's so highly fatal, but also during a momentary transient crisis, it in essence weaponizes emotional distress. And we're seeing over and over again, there's a larger percentage of people who use a firearm, they die in the midst of like an interpersonal romantic partner conflict that otherwise would have sort of calmed down within a few minutes and people could have walked away okay. But when you have a loaded weapon, those situations can become deadly.
And I'm also guessing that lethal means counseling is probably a interesting or controversial topic amongst people in more conservative areas, particularly like here in Texas, where firearms are near and dear to a lot of people.
Mm-hmm. Yeah, it is. It's a tricky conversation, and so a lot of like the lethal means counseling protocol that we developed and tested, we actually developed that while I was in Utah, and so I know that Texas likes to pride itself on its conservatism, but I promise you, as a former Texas resident, you guys pale in comparison to Utah. So Utah is the reddest state in the country, and it is incredibly libertarian, and so the gun culture there is qualitatively distinct, but nonetheless, I mean, there's we're finding there are different types of gun owners. People acquire and maintain guns for different reasons, and what we're learning now is that how we approach that conversation then really kind of depends on who that person is, and so we advocate as well in the lethal means counseling approach to take that sort of evoking process from motivational interview to understand their values and their principles, so that way we can guide the conversation in a way that actually matches who they are as a person and increases the likelihood of them finding the motivation to make that change that could potentially save their lives.
Awesome. Well, with that, I think we're going to start wrapping things up. I'd say I really appreciate the presentation. I think everyone felt this was extremely useful.